Hello, can you hear me now?
We can hear you now.
Is it
Yes.
better?
Yes, that's better. There was a period of time when it was just distorted. It was very slow and
So we're live and we have attendees coming in. We're up 43, 45, 47. So welcome everyone, and we're just going to give another minute for people to come in. We see the room is filling up very fast. It's very nice to see you all. Welcome, welcome, welcome everyone. It's great to see familiar names, some names not so familiar, but we've traded emails. So welcome. So we're going to go ahead and get started. I will encourage everyone to use the Q&A box as we go on. You will notice that we don't have a chat box, but we do have Q&A. So good afternoon, everyone, and welcome to this webinar where the African Children's Hospitals Foundation will be hosting the African Pediatric Fellowship Program. My name is Orade Doherty and I'm your host and the founder of the African Children's Hospitals Foundation. In July, we launched the African Children's Hospitals Foundation with a webinar on COVID-19, highlighting the loud silence on children's health as it related to the pandemic on the African continent. We did so as we braced for an onslaught, concerned that COVID for our children could pose a different, perhaps greater threat than in countries with more sophisticated child health systems. It became apparent to us that the greater threat was to children's mental health, as children and adolescents reported increased anxiety, depression, and situational stress during the lockdown and pandemic period, both at home here in Africa and abroad. These are of concern because of their potential long-term psychological disturbances. We gained some insight into how to anticipate an important and overlooked component of child health, namely adolescent mental health, and highlighted some ways to maintain normalcy during this period, emphasizing frank, open conversations between families, within families, emphasizing routines, and of course, the importance of resuming socializing as quickly as possible and as safely as possible. Our vision as a foundation is for every African child to have access to high quality healthcare that enables them to thrive and achieve their highest potential. And to do so, we also need child health, medical, surgical specialists and teams. Thus, today, we will be pivoting to take a closer look at the specialists who provide care for our children, specifically the African Pediatric Fellowship Program. This program has taken the lead in training child health leaders, not only locally, but is also training physician leaders across the African continent, who are now returning home to set up amazing ventures and teams. It gives me great pleasure to introduce to you all, therefore, without much ado, our moderator for today, Professor Ashraf Kuvadia, the Academic Head of Department, Pediatrics and Child Health at the University of the Witwatersrand and the Head of Department, Pediatrics and Child Health at the Rahima Musa Mother and Child Hospital. Ashraf, welcome and thank you.
thank you very much, Orode. I really appreciate the invitation to participate, and I'm very excited to participate in this session this afternoon. And it really is such a pleasure to be with a number of colleagues that I'd like to get to know more about this afternoon, and hope you will all enjoy that too. But my first task is really to introduce a colleague that I've got to know about only quite recently, Associate Professor Joe Willemhurst, who's actually the program director for the African Pediatric Fellowship Program here at the University of Cape Town in South Africa. And she's based at the Red Cross Children's Hospital. Professor Willemhurst is actually a pediatric neurologist, an interest and head of pediatric neurology at the Red Cross Children's Hospital. She will tell you more about the APFP program, but just to say that this is a program that she's been, pretty much involved with right from the outset. It started in around 2007, and she took over in about 2008. And I'm really very keen, Joe, to hear more about the APFP. So over to you, Joe.
Ashraf, thank you so much, and welcome to everybody. It's so exciting to see you all on. And I can safely say I'm going to talk on my favorite subject. So let me just get my slides up. I hope this is clear for all of you. Here we go. So the area that we're covering, and really thank you to Arodi for giving us this platform through the African Children's Hospital Foundation, is to talk about training in healthcare workers within Africa. And to do that using the model that originated at UCT and is now rolled out across South Africa, and as I hope I will illustrate to you, is gradually working its way out across the rest of Africa. So this is the African Pediatric Fellowship Program. So we are aiming at a strategic workforce development to strengthen pediatric healthcare for Africa in Africa. And why is this so relevant? Well, the issue is, as we know, we've got huge training challenges. And that in reality, if we look at this horrible world mapper, we can see straight away that this is just basic healthcare within Africa, Africa does the worst out of all of the world. And if we look at ratios, there's less than 1 pediatrician per 100,000 children in sub-Saharan Africa. This is compared to 99 per 100,000 in the States. And this is just for primary healthcare worker level, never mind when we then start extending the numbers onto specialists. So what are our challenges that we do face? So most training capacity is based overseas, and this inevitably leads to this horrible term, the brain drain. So where our brightest, most inspiring clinicians go overseas to gain the skills, and then they just never come back, or they come back and they can't stay because they can't do what they want to do. So what are the issues around that? Why offer training in Africa? The reality is the training can be relevant to the African disease burdens, that the content is aligned to local healthcare priorities, infrastructure and resources. It does lead to better retention of returning trainees, and we're combating the brain drain. So the African Pediatric Fellowship Program was envisioned and created in 2007 and rolled out with the first trainees coming in 2008. And our aim is to build a generation of clinicians, educators, and leaders equipped to transform healthcare on the African continent. And the way to do this would be through strategic clinical training of pediatric specialists and subspecialists from Africa to ensure that there is post-fellowship service development support. And through collaboration with alumni and their centers to develop specialist and subspecialist training across the continent. So what is the system for this? So this is the APFP theory of change. And where we start is here where specialists are selected from African professionals to undergo specialist and subspecialist training in pediatrics in a relevant African setting. But then during and after their fellowship, these fellows are supported to develop clinical services, research and training programs, and take on leadership roles in their own institutions and beyond, with the result that the number of trained, qualified pediatric specialists practicing in African hospitals is increased, that African healthcare and training institutions are strengthened, that networks of African child health care professionals provide regional and continent-wide collegial support and collaboration, and that African priorities and perspectives represented in global forums. So the pathway to impact should result in the fact that there is resourced, responsive healthcare systems that are prepared to address the needs of African children. So what sets the APFP apart from other training programs. The work that we've done over the last 12 years has established long-term strategic partnerships with African teaching hospitals to ensure that we don't just boost individuals, but we build pediatric teams, departments, and professional associations. That the African academic partners, they are the lead. They nominate who is the most appropriate person to come through for the training. And it's based on the needs of the local partner institution and the suitability of the best applicant. And increasingly, we found that our alumni are becoming our leaders in the local area who are identifying and handpicking the best person to come through because they understand and they get what will make it work. That the training, when the trainee comes in, is context specific. And this is now available, as I said, at UCT and rolled out into WITS and UKZN. So the capacity has increased with time. And that there's good post-training support and collaboration with those alumni to support them across all levels of interface and action. And reality is that, especially in pediatrics, we don't function in silos. We operate best when we work in a multidisciplinary team. So the main focus of the APFP has been upskilling the number of medical trainees across UCT, WITS and UKZN with the training hubs there. But then actually we've also got capacity to train in nursing through our sister training organisation, CNDPI. That within the APFP, we realized there was a need to train in rehabilitation. And the main focus that we've had at UCT has been physiotherapy. And we've been branching out and looking at other rehab areas. And then the other pilot that we've had running is technologists. You can't function in an ICU or an neonatal unit or in theatres without having good technologists that understand your equipment and can maintain and optimize its function. So this is a unique training model. So in addition to comprehensive and internationally recognized training in clinical skills, the fellows are also equipped with other areas. So there's one-on-one mentorship, not just in the apprentice style of clinical training where they're embedded within the teams that we all operate in, but they're also given skills to help them with the end stage for clinical exam preparations. We also acknowledge the fact that many of these clinicians will not have the luxury of functioning in the silo of their subspecialty, that they're going to have to cover probably the ER and their colleagues. So we will skill them up with other training workshops in other disciplines that they identify as necessary for them. You can't function if you can't communicate. We help the fellows with professional communication skills where needed. You need to be a leader. We want our trainees to go back to advocate and lobby and change practice. So there's access to modules in health and leadership. We also want them to have a footprint firmly within Africa and beyond. So we encourage them to present their work and their research at local and international conferences. We help them through their training with a lead-in, with a reflective essay or diary, which is mentored and supported, that talks about why they're coming for training, that checks they're getting what they need during the training to give us a chance to adjust the nuances of what they need, that talks about what will they do when they go back. Do they have the capacity to deliver the services they want to when they return? And then we ask them at the end to tell us, how's it going? And I hope you're going to hear lots of stories of that once I finish my section. And the other area that we found incredibly useful is that when a trainee leaves and comes to us, often for between 2-4 years, sometimes longer, that it's a long time to be away from home, that often the links with the home centre start becoming stretched. So we encourage them to go back for mid-training work visits, to spend time back with their home mentors, to talk to them about what they've learned, and to talk about where there could be constructive areas to start adjusting services in the home centre that's done in a collegial and a collaborative way, so that you don't have a trainee head back at the end of their training and jump in with both feet, that it's actually done through an agreed process where everybody's involved in the discussion and any changes are viewed as appropriate by the whole team. So what's happened over the years? Well, predictably, the demand just doesn't stop. And you can see that the cumulative number of trainees just goes up and up and up. And then every year we have more trainees coming in. And thank goodness we now have the extended training capacity with the other 2 sites supporting the training program. So at the current time, there's about 65 doctors that are enrolled in the training. And our main restraint is actually funding, because this is a donor-led program, and we try to take the funding burden as much as possible off the referring centres. And who's been trained? Well, there's over 150 health workers that are trained from 14 countries. The majority are in medical disciplines across all areas, including from general pediatrics to specialties to surgery. But we also have the two other silos that are supporting us with pediatric physiotherapy, and then the pilot that we've been rolling out with clinical technology. Now, those numbers would have been higher, but predictably COVID has delayed and interrupted us being able to move forward at the pace we wanted to there. And we're looking forward to expanding that. Africa's often got a bad name for its research potential and activities, and I think you can see here, as illustrated, that is not the case with these fellows. They are prolific, the work they're doing is phenomenal, and their international collaborations are outstanding. Where do they go? So you can see here examples of the return home and the workload. So more than 90% of the APFP alumni work in Africa, and more than 80% of them are in public facilities. This retention is globally unprecedented, and we've checked. There isn't anything else that mimics this. And there are so many examples. These are some that we've pulled out just to illustrate the impact of the program. Within East Africa, there are regional bodies that have been formed, led by the alumni, related to vaccine and immunization advocacy and related to building academies for childhood disability. Within Kenya, with more than 30 specialists trained across the country, they're now well on the way to developing subspecialty curriculums. There was a question that came through about neurology. Yes, Kenya is training child neurologists. They've got 2 that started in March, who were amazing, and they've been networking with us, sharing EEG tuts every 2 weeks. These guys are phenomenal. And other areas are looking at their training. And in fact, as stated, the Kenyan Pediatric Fellowship Program is now in existence, and I hope will become the East African training hub. Malawi couldn't train in general pediatrics initially. It now has its own well-established and phenomenal training program. They still outsource. We get their trainees, they come to us for a short period. They don't need to, we just like it because it keeps our collegiality and our networking with this group going, and they're amazing doctors. Similarly, they're now identifying subspecialty areas that need to be promoted and are going up onto the net scale of promoting healthcare within Malawi. Tanzania likewise identified as one example that neonatology was a huge healthcare need and took a strategic plan to train up as many neonatologists as possible, to the point that they are now reaching the capacity to establish and run their own subspecialty training. Edward Kidger will tell you about the work he's done at MUHAS, where he has truly established multidisciplinary rehab care, working with one of the physiotherapists that trained through the APFP and returned to work with him. Within Ghana, one centre alone trained 13 subspecialists. This group have been amazing. They created their own strategic plan and has systematically, over 10 years, sent through trainees to ensure that they now have a complement of specialists. And in parallel to that, have worked with the nursing program and have been feeding through physiotherapists and now technologists to upregulate their service and their delivery. And the result of that is now working with the centre in Accra. They're looking at the ability to set up a subspecialty training for West Africa as well. So the next hub that I hope is on the footstep of taking off. Nigeria, 15 trainees, amazing clinicians from various centres, also identifying the ability for subspecialty training at various regions. Within Southern Africa, Zimbabwe, again identified neonatology, but not only targeted the need within the country, but took on the role of creating an African neonatal network using collegial support with an ongoing and vibrant WhatsApp group. And these are all APFP alumni who are leading this. And Zambia, likewise. You will hear from Kunda about the neonatal curriculum, the work they've been creating, as well as identifying other key and important healthcare areas. So that's just a short resume of some of the work that's undergone. I would really like to recognise the other 2 sites, and Ashraf is head of department of WITS and works with Pete Cooper, who is the lead of the WITS APFP, and then Lawrence Mwabai, who's my colleague that works at UKZN, and their coordinators, and really encourage those of you listening to please make contact with us. We love hearing from you. We can't always solve all your problems, but we're here and we want this program to grow. And there's the website at the top. These slides will be made available to all the listeners. Thank you very much. I'll hand over to you, Ashraf.
Thank you very much, Jill, for that really comprehensive and in a nutshell description of the African Pediatric Fellowship Program. It really is amazing how far it's come in a very short space of time, and kudos to everyone who's been involved in the program. And what's exciting this afternoon is that for all those regions that you've covered, we've got 6 of our colleagues, 6 of the alumni of the African Pediatric Fellowship Program covering each of these areas. So we've got colleagues from West Africa, colleagues from East Africa, and indeed from Southern Africa, who I'm going to introduce very shortly. I just wanted to say something about process for this afternoon in terms of the webinar, is that we really would encourage questions. However, because it's a webinar, it's not going to be verbally. We're not going to hear you come across with your questions. Put them in the Q&A section and we'll try to answer as many as we can. Please do participate. So it really is my pleasure now to introduce all my colleagues that are going to be talking to us this afternoon, telling us about their experience, and in that way have a discussion around the whole program. I have Dr. Edward Kija, who's a senior lecturer and a consultant pediatric neurologist from the Muhimbili University in Dar es Salaam. And he's at the University of Health Sciences in Muhimbili, and he'll tell you more about, and he'll introduce himself to you and tell you more about what he does. I've got Dr. Sandra Boateng Owusu, who's a senior specialist and a pediatric pulmonologist, and Sandra is based in Komfo Anyoke Teaching Hospital in Ghana. Okay. Then we have Dr. Joyce Balagade Kambugu, and she's the director of the Pediatric Oncology Center in Uganda, in the Uganda Cancer Institute. Then that's Dr. Kunda Mutesu Kapembwa, and she's the head of the Department of Neonatology in the Women and Newborn Hospital in the national coordinator for neonatal services in the Ministry of Health of Zambia. Next is Dr. Nobeta Washaya from Zimbabwe, and she's still in training. She's a senior pediatric pulmonology fellow, and she's currently still in training. So we'll get perspective of someone currently in training. And then finally, we have Dr. Emisola Boyede, who's a senior who's a pediatric neurodevelopmentalist and founder of Ask the Pediatricians Foundation in Nigeria. So welcome to all of you, our panelists today, this afternoon. We really look forward to hearing from each and every one of you. And I'm going to ask you in the order in which I've sort of introduced you. So Edward, I'm going to start with you, and then we'll move across to everybody else. What I'd really like is for you to introduce yourself and then just comment on how you got to know about the APFP program. And then what is it that really was compelling and motivating, or was quite an inspirational aspect of the APFP program from your perspective? And I'd like each of the panelists to likewise make a similar comment after introducing yourselves. So Edward, over to you.
Thank you very much, Ashraf, and thanks everyone for joining this webinar. My name is Edward Kija, and I'm a consultant pediatric neurologist and a senior lecturer at the Muhimbili University, based in Dar es Salaam, Tanzania. I trained in 2013, and I completed my training at my institution. I'm a faculty member. I'm currently responsible for in pediatrics and in child health, and I'm also currently responsible for the pediatric neurology care, consulting in outpatient departments as well as inpatient departments, as well as involved in several research projects that we are currently doing at the hospital. What was really compelling or interesting regarding the African Pediatrics Fellowship Program is the mentorship and the support that the fellows receive at first during the training and as well as after the training. Despite the fact that the various conditions, the diverse conditions that a subspecialty fellow get exposed are quite similar to the home background, usually the kind of equipment, the state-of-the-art care that you see is completely different from what you've been used to or what you've seen during the medical training. So that mentorship that we receive makes learning environment very conducive and very supportive, and therefore enabling the fellow to learn. But in addition to that is the mentorship and support that continues after the training, which I find it very important in order for the fellows, when they go back, to be able to implement and emulate what they've learned. So the ongoing support and mentorship that continues after the training is really outstanding. What I would say that's really compelling for the African Pediatric Fellowship for me.
Thank you very much, Edward. We're all pediatricians, so I hope you guys know that we all call each other by first names, right? So I'm going to move on to Sandra. Sandra, can I turn to you and hear about, could you introduce yourself?
Thank you very much, Ashraf. My name is Sandra Kwatino Usu. I am from Ghana, and I joined the APFP program after hearing of it through my professor, Professor Samson Enchi, who is also currently the head of Department of Child Health at the Konfanochi Teaching Hospital. He's also the Vice Dean in the School of Medical Sciences in Kumasi. So I joined the African Pediatric Fellowship as a pulmonology fellow in July 2016, and I completed in October 2018 and came back to Ghana as a pediatric pulmonologist. And I began to set up pediatric pulmonology service in Ghana. So that's what I'm currently involved in. My focus actually has been in trying to set up a multidisciplinary team, because that was one of the big things that I took with me coming back to Ghana. And I also want to salute my trainers in the University of Cape Town, Prof. Zah, who is the head of division, Professor Zampoli. Congratulations, you've recently been made a professor. Professor Anissa Vanka and Professor Diane Gray. Wonderful team. I would also not forget Sister Jane Booth, excellent super nurse, great mentorship, great support, lovely team, and it was a wonderful training experience for me. Thank you, Ashraf.
Thank you very much, Sandra. Sounds like you really had a wonderful time and made lots of close colleagues and close friendships there. So can I turn now to Joyce? Joyce, can you tell us about your experience and first introduce yourself?
Thank you, Ashraf. I'm called Dr. Joyce Balagade Kambugu. I am a consultant pediatric oncologist in Uganda, where I direct pediatric oncology at the Uganda Cancer Institute, which is the National Cancer Institute in Uganda. But it's also the home of the Center of Oncology in East Africa, serving the country, 6 countries in the East African region. And as of this year, I'm also the continental president-elect for South Africa, which is the International Society of Pediatric Oncology. And I also, since we established our Pediatric Oncology Fellowship Program, the director of this program for now. I trained in the APFP in 2 blocks. So I did my first year of training in 2011 and 2012. And then I went back home and returned to Cape Town in 2016 to 2017 to complete my training. I got to know about the APFP through the executive director of my institution. And this was following my joining the institution as the first pediatrician since the inception of the institution in 1967. And it was immediately clear that we needed to get further training of the pediatrician there, myself, in childhood cancers. And so therefore the ED talked to Alan Davidson at one of their meetings, and then I subsequently went to Cape Town for the training. What stood out for me about this training program, as some of the other speakers have said, is that it's a rigorous program for subspecialist training, but it's also very top-notch and very relevant to our context as Africans and therefore low middle income countries, with all our comorbidities like malnutrition, HIV, things that you would not find elsewhere, and also the need to work within resource constrained settings, and therefore having to prioritize resources and work with teams that may not necessarily be trained in that area. So it's very useful in that regard. It was also very useful because it encourages you to push yourself to your limits and to challenge yourself. So it's not a walk in the park by any means, but it's also done very respectfully and very supportively. So even as you push to your limits, again, you're not broken, you know, so it's very supportive and very respectful. And so I have actually made some of my greatest friends through this fellowship training program and my mentors. And I would say that this program has had the greatest impact on my career as a pediatric oncologist. Yeah, that's it.
Thanks very much, Joyce. Thank you very much for sharing with us. And now I'm going to turn to Kunda. Kunda from my home country, Zambia. And Kunda, can you tell us about your experiences and in your subspecialty and introduce yourself?
Thank you, Ashraf. So my name is Kunda Mtesu Kapembwa. I'm a neonatologist and currently working in the women and newborn hospitals of the university teaching hospitals in Zambia. I'm also working as, apart from the head of department for this unit, I'm working as a national coordinator for neonatal services. And this post didn't exist before, but was because of the need to have someone. I must say I enjoy this post because I feel like it gives me a voice. I trained in 2013 at the University of Cape Town, and I came back home in 2015. And I got to know about the African Pediatric Fellowship Program from the then head of department for pediatrics, Dr. Somwe Wasomwe, who encouraged me to join. I had never heard of it before. And generally, the training was very outstanding. Like many other speakers before me have said, it was very top-notch. And for me, training in Africa was great because it meant that it would be easier to adapt whatever I learned in our environment, given the similar resource constraints. And I've also really enjoyed the collaboration, the mentorship from the unit in Cape Town, Grootes Schuur Hospital. Lloyd took, Natasha, just to mention, but a few were really great. Yes, thank you.
Thank you very much, Kunda. And then I'm going to turn to Nobeta. Nobeta was still a trainee at UCT. Nobeta, go ahead.
Thank you so much for the invitation and this exciting webinar. Anything APFP excites me. So I'm Nobeta Washaya. I'm from Pilo Central Hospital, based in the beautiful country of Zimbabwe. I'm a wife and a mother, and I did my general pediatrics training under APFP from 2015 to 2019. And then I started pulmonology this year. I heard about APFP from one of my phenomenal consultants, Professor Ikiogo, who told me about the center and how it was so excellent. And I must say he was right. So the thing I really loved about this program is how the committee has made an intentional effort to make it a program for us, a program in which we have a voice. For example, with the committee, we've got a fellow who sits in there. So meaning decisions that are made are not decisions that are done to us, but it's decisions that we have a voice in. And they listen to us. So as a fellow, when you've got an idea of how to improve the program, they do listen to us. So for example, the mid visit during the home was a fellow idea, and they listened to that and they took that along. And it's also not a cut and paste program. That's what's amazing, because you'll notice that Joyce has a different route that she took, Kunda took a different route, Edward a different route. Even if you're in the same specialty like myself and Sandra, they follow the route that you want. So it really is an amazing program from that point of view.
Thanks, Nobeta. Thanks very much for that. I guess you have to say that you're still there, right?
Yes, I have to say that. I'm kidding.
Right, no, I'm kidding. All right, so now, Demi, over to you.
Okay, thank you, Ashraf. Hi, everyone, and thank you for joining us on this webinar. I am Bemisola Boyede. I'm a developmental pediatrician. I trained as a UCT Red Cross Children's Hospital in developmental pediatrics from 2012 to 2013. My coming across the APFP program was actually an incidental thing. I finished my general pediatrics in Nigeria, and I was just thinking, what next? What do I want to do? And I just Googled, and I just came across a program that is African-based, and I felt that this is a good thing. I just applied, and luckily I was chosen. And so that's how I found myself in Cape Town, and I went for developmental pediatrics because it's just a subspecialty that we don't really have much people doing it in Nigeria at that time. So I was curious to do something different. And so that's how I found myself in APFP program. And for me, that was a paradigm shift. When I got to South Africa and I saw the way pediatrics training was going and the way the children were being treated at Red Cross, it was something different. I found out that a child on the streets who doesn't have anything will get into Red Cross, and that child will be treated, will get the same treatment the child of the president will get. That was a paradigm shift for me. And I felt that, wow, things can be done differently. And so I was so excited. I'm also excited about the role of the Children's Trust. The Children's Trust is not like the fund that they raise the funds for everything. So as a pediatrician in South Africa, you're not worried about whether this child, where is money coming for the MRI, where is this going to come? If the child is going to ICU, the child is going to ICU and the child is getting all the care, and that's the most important thing. But back home, as a pediatrician, you worry, how we're going to raise the funds, how we're going to get that. So I was very, very curious. I was very, very interested in how things worked. And that was what stood out for me in the training. And then the support, just like all my other colleagues have said, it was something different as well, walking along the corridor with people you read about in the textbooks, and you actually can see them, and then you can have coffee with them, and you can call them by their first name. That was another paradigm shift for me. And so taking all that back to Nigeria, and I think it's been interesting. So going back to Lo then, it's a different thing. I know we're going to talk a lot about that, but the learning helped me to know that you never say never, never give up. And even though you have to work against so much tide, but you can still get things done. And for me, that is how impactful this program has been. Thank you.
Thank you. Thank you. Thank you so much, Demi, for that. Okay, so that's really fantastic to hear all about your experiences. I want to now drill down a bit deeper into each one of your experiences from, and how you've experienced the program. And I want to start off with Joyce. Joyce, I just wanted to ask you, you talked about you being trained first as the first pediatrician in that institution. You were motivated by colleagues to take on the further subspecialization. But can you talk a little bit more about what really motivated you to train further, and particularly with the APFP? If Joyce, you could tell us more about that.
Yeah, so thank you, Ashraf. As you have mentioned, in 2009, when I joined the Cancer Institute in Uganda, I was the first pediatrician there since its inception in 1967. As a result, I was predominantly mentored by adult oncologists. And so the approach there to me as a pediatrician was not the best. It could be improved because children, as we all know as pediatricians, are not little adults. And so almost everything there was, it's a dose of vincristine for a child. Maybe let's give a quarter or let's give a half. there was no clear focused approach for pediatric oncology patients. And so as a result, the quality of care, the morbidity, and the mortality of the children with cancer was fairly high, and I felt it could be improved on. And I'd already done as much as I could in the 2 years with regard to improving the general pediatrics aspect. So things like dying from malaria or diarrhea with severe dehydration and so forth, for the most part, had been improved upon. But the actual reason that they were there was no focused approach. And my mentors could not also help me much in that regard. And yet, this being the National Cancer Institute, there was a need, it was a national referral center, for us to have an approach to these children that was locally responsive and that was based in science and not, I think this, I think that, or I think the other. And so for me, there was a lot of pressure on me, both personally and also from an institutional perspective, to be able to have a strategic response to these children within the institution, but also nationally with regard to these children. And I didn't know what to do. So the training was very appropriate for me because I would then be able to say something because I know that this is what it should be, and to be able to direct the agenda in the country from a position of knowledge. And this to me was very important because I know, as most of the people in Africa, it becomes very difficult for you to advocate or to change policy or anything at all if you're not appropriately trained to stand up and say, therefore, I want this. And for it to be recognized and respected as a position or as a demand. And so I was motivated to go and actually get this training and perform my role as the head of pediatric oncology in the National Cancer Institute.
You muted, please. Oh, there. Okay. Great.
Yeah, so that's it in summary.
Thanks. Thanks very much, Joyce. Roberta, similarly, I'd just like to find out, you've now been training for the last several years at UCT, at Red Cross, and you've decided to extend your training even further. One would have thought you'd want to go home by now. Tell us why you're motivated to continue to train, Roberta.
Okay, so towards the end of my pediatric training, I decided to choose a subspecialty that I knew would make an impact in my nation. And we all know about the lung health burden. So pulmonology was a good fit. And then there's the thing of when you become a subspecialist, you kind of tend to forget your general peds. But now with pulmonology, I've got the general peds because each system gets is dependent upon the lungs. I'm obviously a pulmonologist. So for me, it was a good fit. I'll have my general peds and I can help a lot more children in Zimbabwe. So the decision was I could go elsewhere, maybe overseas and train, or I could stay in Cape Town. And first and foremost, the logistics were easier. The logistics were easier for me to just finish everything all at once and then go home once, and to be in a place that I already knew. If I went elsewhere, say to Europe, I would still need to get registered. I need to get to know the system. By the time I know the system, it's time for exams. So at least I'm in a system that I already know about. And then, like someone already mentioned, the patient burden in Zimbabwe is the same patient burden in Cape Town. And I have managed some Zimbabwean patients in Cape Town. So I'm not going to see much TB in Europe, but I will in Zimbabwe. So Cape Town, South Africa, anywhere in South Africa would be appropriate for my training. Okay. And then, as Sandra mentioned, the team dynamics of the pulmonology team. I rotated in the pulmonology team when I was still a general pediatric registrar. Even though I was the most junior of the team, I never felt like I was the junior. I felt like I was part of the team and I did the same kind of work. And I was like, you know what? When I'm a consultant, super consultant, that's what I want to be like. And to me, it made sense for me to spend time with the people that I want to be like. So the team dynamic is amazing, from the nurses to the physiotherapists. So that was the decision. I want to be like the people that are training me. So yeah,
wow.
So I stayed.
Really fantastic endorsement of your trainers and the whole team. So let's stay with pulmonology, since the lungs are the most important. And let's go turn to Sandra. Sandra, can you tell us about what really stood out for you? I think you gave us quite a nice introduction, Sandra, as to your time and the training program. But when we were chatting earlier in the week, Sandra, you really, you said things that really, stood out for me as to the impact that this whole program has had for you, Sandra. So if you can share that with us.
Thank you once again, Ashraf. So I think what I would say was actually overwhelming for me was how much the consultant trainee time that was allocated for us. And it really stood out for me that if this program has been set up and the people who are part of the program really are there to make sure that the trainees truly get trained. So, I mean, Noberta will tell you that in pulmonology, there's never a dull moment. There's always something that is up to be done, making your case reports, preparing your BAFs, preparing for the next week. There are a lot of things that the consultant input is really so massive. And I think that is something that I took with me as a trainee then, and now as a supervisor, that if I commit to, for instance, to a student's research, to a presentation, if my student is presenting an abstract, is doing anything anywhere, that I must be part, I must contribute time to it. I know we don't have time, so I can't share a lot of images, but I wanted to just show how much a team force. And I also want to salute my colleague trainees who were with me, Dr. Diana Marangu, who is in Kenya, Dr. Shakira, who is now busy with her PhD in South Africa. She taught us so much. She spent time to get us oriented with the program, and that was also very instructive. And I also will not forget Dr. Ayuk, who is also from Enugu in Nigeria. So there was a lot of teamwork right from the consultant aspects of it. And it wasn't like something that is given to you on a silver platter. No, you had to work, you have to make input. But then they were there to hold your hand through making your consults in the emergency room, which can sometimes be very frightening, especially when you see the very big folders that the patients have, which meant that they've been seen many times, a lot of input has been made, and it can be frightening. But I think you pick the phone to call and say, we have patients ABC in the emergency room or in the ICU, I've seen the patient, and they are ready to support you. I remember one evening, Prof. Vanka had to drive in, it was raining, because there was a case in the emergency room, we needed to put a chest drain, and she was right there to hold our hand. So those were big things that's for me, I would say it was overwhelming, and I really have taken something from that. Consultant trainee time is excellent in the APFP training program. Thank you, Ashraf.
Thanks very much for that. I also got a sense from what you were saying, Sandra, that amongst the fellow trainees, there's quite a bond that sort of develops, a camaraderie and a sort of bond that I'm guessing goes beyond the training period, right?
Yes, because it's a lot of work. In fact, before I went to Cape Town, I didn't know there was so much to do with the lungs. And I actually thought that beyond pneumonia and asthma, there wasn't anything else in the lung. But then you realize that there's so many different, even for the airway, you know that it is a shared airway. So the anesthesiologist has a role, the ENT surgeons, but very much so the pulmonologist also has so much. So a lot of cohesion is needed to discuss cases, present here, and you cannot do it on your own. So here again, I emphasize teamwork that is so relevant, and that is very prevalent in the pulmonology team, not only with the doctors. Professor Morrow, for instance, Brenda, who is a physiotherapist, extremely intelligent, will teach you a lot of things with all the other team. I've already mentioned Sister Booth. So it's not only the doctors, but it's everybody. I remember my very first time that somebody told me, could your patient be aspirating? It was a physiotherapist. And she said, okay, you're seeing this patient, he's not improving. Have you asked your consultants about, do you have to consider pulmonary aspiration? And I was like, what is that? I mean, that was like my second week of training. So everybody in the team, the multidisciplinary aspect of the training is also very important. And I emphasize here that no single doctor can be effective without the team. The team aspect of the training is also very important. Every member of the team plays a very unique role and a very significant role. And that is a very big plus for the APFP training. Thank you, Ashraf.
Thanks, Sandra. Thank you so much for that. Jamie, you're one of the fellows that really looked out, and no one really pointed APFP in your direction. You sought out further training, and you obviously had certain aspirations you wanted to meet, Bemi. Do you feel like the program met with your aspirations, or do you feel like you went into a different direction? Was it met? Were your original intentions met and aspirations met, Bemi?
Yeah, thank you, Ashraf. Yes, I can categorically say that my aspirations were met. In fact, exceeded in terms of my training. So I went there to become a developmental pediatrician, which I successfully completed. And one thing about this training is not that you are just getting the training, which is good enough, but you also get the qualification to go with it. So you are encouraged to complete and do the exam, which is an exit exam, and is apart from the fellowship, with the Colleges of Medicine of South Africa, you also do a MPhil program, a degree program with the University of Cape Town. So you are getting two qualifications simultaneously. So I got my fellowship in subspecialty of developmental pediatrics in 2016, and the same thing with my MPhil in developmental pediatrics, with a distinction as well in my thesis. And also you're encouraged to publish your papers. So I think I published most of my papers during my time in South Africa, and I also got grants. So I got grants locally from the UCT itself for my research. I also got grants from the Infectious Disease Society, because they know that anything you're doing with Cape Town is something genuine, and so for somebody that comes from a country where for you to do anything, you have to do out of your pocket. So it's very interesting to be in a setting where you actually get funding to do anything you want to do, and all the supports were there. So I felt that most of my aspirations were met personally throughout my training. And then apart from the career aspirations, there are other things that you also take away, and that is the fact that things can be done differently. And for me as a pediatrician, it's about saving most of us are pediatricians because we don't want our children to die. We want to make sure that the children are saved. And some of the things I learned during my training also helped me now to look forward to how do we improve the statistics in Africa. And that is actually what motivated me to start my Ask the Pediatricians Foundation, which is something that's really helping and helping the children in Africa, helping the parents to know about the health of their children and how we can reduce deaths that are preventable. So for me, I think APFP has far exceeded even the aspiration I had at the time I started it. Thank you.
Thanks, Benny. Joyce, similarly in pediatric oncology, you went back with the skills that you needed in pediatric oncology back to Uganda, Joyce. Did you feel like your aspirations were met? Were there further things that you would have wanted to have got out of the program?
I think that if there is a way in which to say beyond strongly, I would probably apply that. I think that my aspirations were strongly met, and even more than I had anticipated when I went for this fellowship training program and then went back the second time. For the following reasons, and perhaps more that I can't elaborate on in this very short time. But I went there to be able to treat children better from a scientific knowledge and skills, to improve my knowledge and skills space to be able to do pediatric oncology in Uganda. But when I went back, I was then able, because of what I experienced at the Red Cross, to establish then a dedicated pediatric oncology service from the whole one-size-fits-all institution where everybody was like mishmashed together. And so gradually I established this service with, of course, support of the institution, but more importantly, with ongoing mentorship from Alan and Mark and everybody else at the Institute, who I want to thank very much. And so gradually from being allocated a corner with 12 beds and 6 nurses, serving about 250 patients at the time in 2012, to eventually having a 40-bed ward that's dedicated to pediatric oncology and the staff of about 24 nurses now. And annually, we now receive about 600 new patients. So we are gradually, from a clinical arena, occupying that space that we were supposed to occupy from a clinical perspective that's tertiary and receives children from all over the country, as well as some of the neighboring countries in East Africa. And so I've been able, because of that service, which I didn't expect, to influence the agenda or the landscape of pediatric oncology in the country, but also in East Africa, because our institution is the home of the East Africa Center of Excellence, with a 4-pronged mandate for clinical care, which I have expounded on, but also research to be able to develop or spearhead the research agenda in pediatric oncology that's locally responsive or relevant. And then also for training, which I've been able to do again with mentorship, because right now we have a pediatric oncology fellowship program at the institution. And then policy, which I might then be able to talk about later when I have an opportunity. But research or the pediatric oncology policy matters are very important, because they help to direct an agenda in a more focused way rather than mishmash. And so as director of pediatrics at this institution, I feel confident in occupying this space. Whereas before, I just felt like I was swimming around with this title, but not really sure what I'm supposed to do exactly. And so that crystallized in my mind as a result of this training. And also because of this mentorship that I have had, this training, as well as after the training, and being able to understand beyond the Uganda context, but pediatric oncology in developing countries, pediatric oncology in Africa, as I continued more and more, even after the training, to interact with my mentors there, it's one of the reasons that I am now the continental president-elect for SIAP in Africa, which I really didn't expect when I went for training. So where my aspirations met when I went for the fellowship training program, I think, yes, they were more than met. And I hope to be able, because of that, to occupy this space even better because of the APFP.
Oh, that's very inspiring. You know, to me, it's as though many people's aspirations were met unknowingly when you've gone there, not just your own. I mean, the country's aspirations to be able to treat pediatric cancer patients more, appropriately, and not having to refer them or see them die. So it sounds like you've got a huge role to play, and APFP has really played a big part in making you capable of playing that role. Sandra, for you, I mean, I want to turn to you, Sandra, and just talk to you again about going now into the APFP program. How would you distinguish it from another training program? You know, like what for you, Sandra, made APFP different? I mean, what if you're able to answer that? You know what I mean? Like,
yeah, Ashraf, thank you once again. So, what is different about APFP? So, right from the start, there were lots of meetings with the trainers about what can you take back home. We know you don't have all the infrastructure. For instance, I'm not doing bronchoscopies now because, I mean, Prof. Zampoli knows we've been busy searching around looking for a scope that is moderately priced so we could have one. We are still at $40,000, and so it's quite expensive. But then we have not only focused on big things, simple things. What can you take back with you? So for instance, sputum induction, which we were not doing before I left Ghana, was something that I found very useful. Does not need a lot of technology. And I took that right back home with me. How to identify patients with other problems and make inputs. And in addition, I think what was very, very important was back again to supervision for my MPhil. So my supervisors, and I would salute Prof. Zampoli and Prof. Moro once again, they were like every step of the way with me. So I had to go and collect data from Johannesburg as part of my research. And Prof. Zampoli flew to Johannesburg the same week I had to go there. We had a meeting with the department. And so that you feel like you have somebody holding your hand. That was my first time really entering Joburg. I had never been there. And everything sort of was really planned. So that was something that was really great. And there again, I would speak about Prof. Zah, because she's so much into this African idea of raising up African leaders in terms of research. And she's like almost every time asking you, what can you do in terms of research? How can we collaborate? What can we do? And we found so many ideas that we could take back home and share. It would interest you to know that last year when she came to Ghana for a different meeting altogether, we had, she quickly arranged a meeting with me so we could talk about where are you, what can we do? And then the last thing to say is the APFP visit that came to Ghana last year. So if you know a lot about the APFP multidisciplinary team visits, every year they select one country to visit. And so last year, the torchlight was on Ghana. And I felt so good about myself seeing my supervisors come around, the ICU team, Prof. Moro, Dr. Sally in ICU, Sister Booth came to Ghana once again. All these great people, the speech therapists, the physiotherapists, and the occupational therapists. So as I said early on, it's a multidisciplinary approach. And flying to Ghana, seeing my patients with me, we even had a clinic session together where I discussed my difficult cases with Prof. Zampoli and the rest of the team. They had so many sessions with the registrars. And it's so reassuring that you are not left on your own. Even after the program, they are always checking on you. Where are you? Where are you? How can we help?
It's not simply just the training period and getting your skills, but it's establishment of a sort of a relationship and a post-training mentorship, or almost lifelong kind of link.
Lifelong partnerships, if you would put it. So it's great. I found myself in Liverpool in 2019 last year because Prof. Zampoli recommended me for the European Cystic Fibrosis Association's annual general conference. I was selected. I got a travel grant. I got to present my MPhil work. It was so amazing to see all the people, your supervisor right there. So you are assured that if any big question comes, somebody's
I hope it was impressive.
It was impressive. And we met some of the very big names in cystic fibrosis world. And he was like all over the place, Sandra, come and greet this person. Sandra, come and greet this person. It's like they have the confidence in you that they have trained you. You are good enough for the outside market. And those spin-offs, in fact, when I was going into the training, I knew I was going to learn and come back home. I didn't know I was going into a new family. I didn't know I was going into a place where I would pick the phone at 12 midnight and say, oh, I have this case. I don't know what to do. It's an upper airway obstruction. Should I request for a trachea immediately? What should I do? I mean, and they are sort of always willing to respond. Sunday mornings. And so it is a great program, not only for the teaching, but for the family, the lifelong partnerships that you establish. And that is great. Many conditions that you will not know of, you learn about it, you come back home and you begin to see it. And so I think these are big things that I have taken with me. I continue to learn from them, and I'm really grateful for being part of the training. Thank you, Ashraf.
I want us to now turn around in this discussion and just consider now just kind of what Amy was saying about this post-training period. Once you get back home, you've got this huge responsibility that you now have to face, as Joyce was telling us, sometimes bigger than you think. And then how does it feel? Like, how did it feel for you? And I want to ask you about that. Can you tell us, when you went back to Lusaka, to the University Teaching Hospital, Kunda, challenges? Can you tell us anything of your experiences, the highs and the lows? Talk to us about that.
Okay, thank you, Ashraf. Coming back home was a bit challenging because the adjustment was met with certain challenges. Of course, there'll be obvious issues of the lack of equipment, the inadequate infrastructure, the data collecting tools, and then just working on the ground. You find that you have no teams to actually work with because at this point, the language is different. And then you also find that it was a bit difficult to change the mindset. Where things were done differently, you needed to be patient for people to get you. There's this thing of feeling like when you tell people what should be done, you're coming out like you know it all. So I met with various levels of resistance, and I realized that I needed to be patient. And sometimes I didn't need to talk, but to actually do what I had learned for people to see that the outcome would actually be good. But despite all this, there were a lot of successes that were there, and these have actually included, making a short-term training program, and all these things were because of the national coordinator position. So
You have a training program.
We do have a short training program. So what happened was the protocol that we had in Cape Town, we got permission and adapted it to our setting. And speaking to this protocol, we came up with a short training program where we actually teach low cost interventions that are highly impactful, including kangaroo mother care, prevention of hypothermia, the supportive management of asphyxiated babies. And so we've been piloting this training, and we've piloted it in like 5 provinces out of the 10, and we hope that we get to see some results. But at local level, at the facility level, we've actually seen that implementing the protocol has resulted in a decline in mortality from about 35% in 2017 to about 25% currently. Then one of the other successes is actually that we started the postgraduate diploma in neonatology for MO type doctors, the senior house officers, and we are actually graduating the first cohort of 9 students at the end of this year. I must say that these individuals are very highly skilled. They are not pediatricians, but and you can't call them neonatologists, but they've got very advanced skills in looking after neonates. We've continued capacity building in the undergraduate and postgraduate program because our neonatal unit is the largest referral facility in Zambia. And so we have the MED program, and the MED students actually do come to rotate. And this has been successful because most of them will go back with the skills that they didn't have. Have been involved in development of curriculum for neonatal nurses, like we are talking about teams. It's very difficult for one to work alone. The nurse is very, very cardinal when it comes to neonatology and other programs, because the nurse will be on the ward, yes, for a longer time than one would be there. Yeah. Then I think one of my biggest failures is that I failed to find suitable candidates to actually come and do neonatology for 24 months, because I realized that it was difficult for people to leave their families. It was easier for me because I moved with my family. My husband was doing nephrology at Stellenbosch University, and then I was doing neonatology. So we carried two of our kids, and it was much easier. But I'm hoping that there's one candidate now who has just finished her MEd program that we should be starting the application process, because I feel that if we have more neonatologists, then we'll create a critical mass to actually start a fellowship program. Thank you, Ashraf.
That's wonderful. I have no doubt that you will at some point get to start a fellowship program. And I think that actually is the philosophy of this whole program. You know, as I've become to learn more and more about it myself. Edward, what about yourself in Dar es Salaam? What was your post-training experience when you got back home?
Yeah, so some of the things, Ashraf, I think Kunda has mentioned. So I think the biggest thing is once you come from such kind of level of training where you do learn some top-notch, state-of-the-art care of children, coming back to implement that, it comes a bit of a challenge, because you do not have all the luxury equipments that you could request, even for poor babies. Babies who are coming from very poor family, they'll still get the same expensive investigations that you could get in Cape Town. So that was a big challenge in trying to actually implement what I've learned. But the other thing which was also a bit challenging is managing expectations. Because once you come back and you have learned and you're now a subspecialty, and then everyone expects that you're gonna be this superhero and then you're gonna fix everything. So that was also, yeah, so that was also a bit of a challenge in trying to manage, because it now became overwhelming. For example, our neuro clinic that was there before I came used to see around 20 to 30 in a day. But all of a sudden we start getting referrals and referrals and referrals. And now we get to see, in our very good day, we see up to 60 to 70 in a day. In a very bad day, we can go up to 100. So a clinic that usually do for 3 hours, we end up doing for 8 hours. So that was has also been quite a challenge in trying to navigate into that. The other thing was the issue of advocating. Once you know how it should be done, and it can be done even with the kind of resources you have, to advocate for the hospital administrations to get some equipments, to try to change the mindset of doing things differently, better, because most of the subspecialty, most of the African countries do not have many pediatric subspecialty. Most of the subspecialty that there are adult, and adult things do slightly different. So when you try to advocate that this should be done in children, trying to change the mindset, that was also a bit of a challenge. But through negotiations and some communication skills that I think Joe had talked about has helped a bit. Now we are going into the right directions. In terms of the success, I think I've been quite fortunate. So now we had established the first dedicated pediatric neurology clinic in our national referral hospital, which is purely dedicated to pediatric neurology, and we're seeing different conditions, things that we didn't use, or we are seeing, but we are not diagnostic before. Now we do. Things that people used to think is just cerebral palsy. Now we understand there's more than just cerebral palsy. There are other neurological conditions that could mimic that, and therefore we have somehow improved the care of these children. In terms of even building teams, we have managed to establish, to improve on our electrophysiology unit in terms of training our technicians. Most of our technicians earlier they were nurses who were just trained on the job on how to put some leads and switch on the equipment. But through the collaborations and the team that we've built through the APFP, we've managed to train them online, and now they're undergoing training, and soon they'll have certification for that, which I think it's a big milestone in terms of improving the teams. I think most of my colleagues talked about teams, and I think it's key in terms of improving the care. And we've been able to do that through our technicians, as well as in collaboration with our multidisciplinary team. We have also established a rehab unit for children with some neurodevelopmental disorders. So that kind of a success is really encouraging, as you can actually see that the training that you received and the work that you're doing is actually making a positive change towards improving the care of these children.
Thanks, Edward. I think the theme of teams having to be trained at the sort of same time and around the same sort of subspecialties is coming through very clearly. And I think it's one that we all have to think about more, rather than just think about individuals that need to go back with a certain set of skills. Joyce, I want to turn back to your experience in Uganda and ask you about, are there any, can you give me examples of tangible outcomes that have resulted as a result, apart from the fact that, you know, you're holding such a vital position now as the national coordinator, but have you seen an impact similar to what Edward's seen in terms of numbers of kids coming through into your clinics, or has policies changed? Are you there, Joyce?
Sorry, I had muted myself. Yeah, okay. So yes, definitely there are many things in terms of tangible outcomes, but I will mention a few things. So I mentioned earlier that now we have a very high volume service, but despite that, obviously when you have high volumes, it affects the quality of care that you're able to deliver. And this is an ever-moving target that we try to improve with advocacy. But one of the things that I can say is that we've had definite reductions in morbidity and mortality. I remember when I first went to Cape Town, on the first weekend, I came in to the round and I was asking my colleague Jack at that time how many children had died. Because it wasn't uncommon for you to come home, to come on the Monday and find that the entire row of 8 children had passed away. So things like those don't happen anymore. So we've had definite impact on morbidity and mortality of the children, despite the high volume of numbers. And also through advocacy, we now have, because children at the Institute are just 10% of the population. And so if you look at things like equity, in the past, pediatric drugs, for example, were not high on the agenda because we're just 10%. But obviously now, through advocacy and so forth, we have definite improvements on the representation of pediatric drugs, for example, on the essential medicines list for the institution. And other things like radiotherapy and things which are specific for children, which are key to treatment of children's cancers. And so I could possibly say more about this, but because of what we're able to do, it's not only now a pediatric oncology service that was seeing children up to 15. We are now strategically extending that to a fully fledged pediatric and adolescent service. And this is because of all of this that we have been able to achieve directly as a result of the training that was offered to me when I was in Cape Town. Another big thing that I could mention here is from the research perspective and the research agenda or the research landscape of pediatric oncology in the country. So in the past, we had very opportunistic research that was fragmented, and it depends on what collaborator X or collaborator Y wants to do because they're coming in with the money. But and even then it was mostly focused on back because that's what everybody knew, and the people who came to Uganda were interested in that. But now we have moved away from that because of all this that I now know, and my colleagues now, to have a very deliberate, directed research agenda that has priorities that will help us to determine where we want to go and have a very deliberate evidence-based approach to the management of our childhood cancers, which I think is very good. It is still collaborative. We're a resource-constrained country, and the governments don't spend a lot of money on research as a rule. But we're now able to advocate and put your foot down from a position of confidence and say, look, I know you want that, but this is what I want. And so we find a very nice confluence where our needs are better articulated and the research agenda for pediatric oncology is better managed because of that. And I know that the fruits of that is going to be us knowing our metrics and also being able to practice pediatric oncology in an evidence-based manner and not just ad hoc. From the training perspective, yes, I talked already about the fellowship training program, but we also have now more robust training of residents so that we have, as you know, they are much, much more than we do, and therefore their impact on early detection or early diagnosis of childhood cancer, because they go all over the country to set up or to join the pediatric general pediatrics units. And so we have training packages for them when they go through our unit. And we also have packages now for post-training packages for pediatricians who are already in service and other lower level health workers. And again, this is because of this training that I received, and therefore having a bigger view of pediatric oncology from just department, but now to a more national stance. One of the biggest things I can say that has been tangible for me, because I understand better the landscape of pediatric oncology, not just in the country, but outside of the country, for me, or experiences that I gathered from there, is the importance of a national cancer control plan. And this national cancer control plan, that where you are able to influence and deliberately ensure that pediatrics is taken care of, because then you're able to fight for your slice of the cake with regard to many things in the country. So now we are able to then have a coordinated response to childhood cancer in the country, where you have a proper knowledge of what is there now, a baseline, where do we want to go, and it's clearly articulated in a document. And so that all the different players in the country are able somehow to fit in with this, and you're able to measure where are we vis-a-vis where we want to go. And I think for me, this has been very critical, because I now understand the impact of such a document. And so we're in this process. I'm always there haggling, because I know what it means.
I can see you being a fighter. I can see you being a fighter, not letting the adult colleagues.
Yes, and I have insinuated myself into those meetings to be able to advocate with a very strong voice and use whatever instruments are available, including coercion, to make sure that the agenda of pediatric oncology is appropriately covered. In the interest of time, I will not say much more than this, but these stand out for me as tangible outcomes of the training that I did receive, and the ongoing mentorship that I have to mention. I have from Prof. Alan Davidson, Mark, and all the other people that I still up to now interact with and bounce ideas off of. And sometimes I go to them and I'm
wonderful. That's really good to hear, and I think that was always the intention, that linkages remain strong. Edward, I want to turn to something different. I'm an academic in an academic institution, and I'd like to know how your training, and this applies to everyone on the panel, how has it rubbed off your training onto the undergraduates and the postgraduates, the registrars? You know, what impact do you think you've had, if any?
Yes, thank you, Ashraf. Like I think I mentioned earlier that one of the things that really stood out for me was how the mentorship is being conducted through the APFP, how you spend so much time with your supervisors doing everything. I remember during my time, you would walk around with Joe from the general wards to the ICU to the general pediatrics, and you do everything. You spend almost the whole day together until everyone departs for their home. So I've kind of emulated that type of mentorship of spending time with my trainees, whether it's undergraduates or postgraduates, doing everything with them together from around whether we are doing it inpatients or we are doing it outpatients, but actually spending more time with them so that they do get some of the skills that I've trained. But in addition, apart from that, mentorship is also trying to influence at a slightly wider picture, because one man cannot change everything. So you need to somehow have a bigger team, or to use some other strategies in trying to reach more people. And one of that is we did that through the revision of the curriculum that has been done through our university. And we have tried to improve the pediatric neurology section or segment through the undergraduate as well as the postgraduate training, but also try to improve overall general pediatric training in kind of improving how patients are being assessed, how patients are being approached from the clinical point of view, as well as from the assessment and care that I had received in Cape Town. But in addition to that, I was fortunate enough to be involved in the development of the Pediatric National Guideline and Essential Medicine List. And I have to say, prior to that, there were only very few medicines which were listed into that regarding some of the neurological conditions. And that, of course, had the implication in terms of how the government is going to budget and what medications are going to be distributed. So as a result, most of the kids were not getting the required medications because they are not there in the healthcare facilities. So fortunately enough, I was involved into that, and I was able to advocate and ensure that most of the medications that will be useful for children with neurological conditions are actually included, so that somehow the government is obligated to purchase them because they are in the National Essential Medicine List. And therefore, it is in the reference. So even if you have in some other regions, other healthcare providers, they'll say, okay, we have this medication which we can use for this and this condition, and it is in the essential medicine list. So the government can actually budget for that and purchase for that. So I think that has been one of the success in terms of improving the bigger picture, in terms of having a bigger impact, not only at the institutions or at the trainees that I have, but also in other kids whom they may not be able to see a pediatrician, or they may not be able to come to our hospital. So at least they will have those spin-off effects.
Amazing, really amazing. Edward, just staying with you, I'd like you just to say a word or two about what the alumni community is like. How are you experiencing it? What would you say to others to share your experiences of the APFP alumni community? You know, we heard earlier that there are these sort of friendships and bonds that get formed amongst trainees from various parts of the continent, including those in the country.
Yeah, so I have to say, Ashraf, so the family that the APFP, the alumni have, you kind of develop a family because the support that is providing among each other helps you to bond and develop a long-lasting collaborations that has been happening to me personally, in addition to my mentors, whom I still be in contact with and consult them as I need them. So, for example, with my colleagues from Kenya and Uganda and Ethiopia and other East African countries, we've managed to establish what we now call East African Academy of Childhood Disability, which has been a very important organization in terms of raising awareness for childhood disability, in terms of educating parents on childhood disability, and also advocating through government in terms of improving service provision, in terms of improving access to care for children with disability. But in addition to that, we've also been able to collaborate. The friendship that that has developed through the APFP has allowed us to continue to collaborate. For example, right now we are doing a multi-country study with my colleague and a good friend of mine, Charles Hammond from Kumasi, who works with Sandra. I think Charles is also probably on this webinar. And we are doing that study as 2 pediatric neurologists from 2 different countries, including other countries, Malawi, Nigeria, and in India. So that collaboration, that even we train together, and then we continue being friends, and now we are doing research together, and possibly will continue collaborating and bouncing off different difficult cases among one another and helping us one another. And in addition to that, there's also another organization which came up from the alumni. So there's also some called East Africa Center for Vaccines and Immunization, which is being led by a very good colleague and friend of mine, Dr. Mbeva Malande, who is a pediatric infectious disease specialist whom we trained around the same time at the University of Cape Town and Red Cross, who is basically promoting access to vaccines among children across East Africa to make sure that access to vaccines among children is improved. And therefore we prevent conditions which are vaccine preventable. We prevent comorbidities and we prevent mortality, which could easily be prevented through vaccines. So in a nutshell, Ashraf, in the interest of time, I would say the APFP provides a family. It gives you a new family that you go on, you meet your mentors who you will continue collaborating with them. They'll continue to mentor you. They'll continue to check up on you to make sure that you have a career progression. But also you meet these different colleagues in different disciplines, which allows you to make new friends whom not only you'll continue to collaborate in terms of discussing difficult patients and consulting, but also you can continue collaboration in terms of other big grants and research projects that you can continue doing multi-country with different colleagues from different countries.
Thanks, that's so good to hear, Edward. Thank you very much for that.
Well, Ashraf,
yes?
Sorry to interrupt you. There are quite a few questions on the chat about specific to asking our alumni about one of them, for example, is would you recommend a full 2-year program for subspecialization in pulmonology? Somebody else wants to know if we have Peds Gastroenterology Fellowship offered. So I wonder if the alums would be able to take some of those questions.
Sure, and I wonder if we can direct some to Joe in terms of the the overall program, if they're problematic ones, around how long can the program go for, and I suppose it depends on the discipline. I think we will have some time for the audience questions right now. I wanted just to wrap up on the last sort of, maybe we can make it 5 minutes with perhaps one sentence each from each of the panelists, just in terms of, can I just put it to each one of you the same question? Is there anything that you feel that you'd like that the APFP could be, like, if it had to improve its model, what would that be? And if I could start with Nobeta, and just in a minute so that we can get to the audience questions.
Okay, I guess people have already alluded to how difficult it is to make changes when you go back home because of the difference in mindset, as well as you can't do everything on your own. The program is already training teams, but how about the program trains teams at one go? So for example, if Zim is saying we want to build a cardiopulmonary unit, we need an anesthetist, a pulmonologist, a cardiothoracic, a physiotherapist, speech.
All at the same time.
Yes, so they all train at the same time. They plan at the same time, and when they finish, they go at the same time. And so within a year, you've got a unit that can make changes. And within 5 years, you can definitely have training. So, sure. And yeah, and you can divide them across the 3 centers. They don't all have to be in UCT, for example. So you can have 4 in one area, 4 in one area, 4 in one area. So application is coming from the university, yeah, rather than from the individual being supported by the university.
Sure. Thank you for that, Nobeta. Sandra, what would you say to Joe and to the APFP program designers about what could change?
Thank you, Ashraf. I think for me, I would say not a change per se, but similar to what Nobeta has just suggested, that I think APFP should begin to look at another hub, which is West Africa and most likely Ghana, because yes, it's lovely to come to South Africa, but I think as a mother trainee center, I think maybe if we could spread our wings to West Africa, to Ghana, for instance, because in my center, there's almost every training. So there's pediatric intensivist, there's pediatric nephrologist, there's pediatric neurologist, there's gastroenterologist, there are 2 oncologists, there's pediatric emergency. So I guess we need to begin to talk about really setting up for West Africa.
Hubs, sort of local hubs.
Yes, and even talk about the nursing team. There's a big nursing team with highly developed skills. So if I would say something to Prof. Wormhurst, I would say, let's begin to talk about something similar APFP in Ghana, in Kumasi, because I guess we are nearing the point of being ready to take up subspecialist training.
I think that's part of her vision.
As part of our vision.
And her vision too.
Yes.
So Joyce, what about Uganda? Do you think what would you say about the APFP program in its evolution going forward?
I had a very, very lovely training experience. There are a few things I would change about it. However, and some of the other panelists have alluded to it. Training and getting the knowledge and skills base is one thing, but being able to actually influence things back home requires a certain other skill set in leadership, knowing how to advocate, knowing how to lobby, and knowing how to appropriately put your point across in respective institutions and countries. And that knowledge and skill set is a challenge. And I think also the people in the Red Cross might not actually know how best to help you with that, besides leadership programs and so forth, which now have been inculcated. But I think it would be meaningful for there to be, just like you have training African specialists for Africa, the alumni have each gone back and experienced some of these things and might be actually better placed to articulate and prepare the APFP fellows better for what might be coming at home. So kind of like experience-based skills from what I went through when I went back home and some of that. So something like that could be put in place, and it doesn't have to be a whole month of things. It can be something ongoing, like one session a month of how to manage XYZ when you go home, so that as the trainees go through the program, they get to think about this. How do I manage aggressive units back home? Like I went back to a unit that was mostly adult-based. How do I advocate and carve out something for children? Or a resistant health system, or a place that's being dominated by a collaborator from a high-income country. How do I go about that? And that can be better addressed by people who have faced this, and then they can do some kind of one hour.
Yeah, if you want to be an agent of change, I mean, those are very key points. Agent of change, not just your specialty, but it's all these skills of negotiation, leadership, advocacy, etc. I think in the interest of time, and Nobeta, Amy, and Edward, I'd like to hear similar comments, but let's move to the questions from the audience. I really want to be respectful to everyone who stayed so long, and we really appreciate it. Let's try and take our audience's questions, and they really want to hear from you. And so let me try and some of these might be directed to you, Joe, as well, as being part of the panel. I'm going to try and look at the questions that have come through.
I should put them on the chat group. I hope you can, is it easier for you to see them?
Oh, that would be
If you open them up, I've numbered them 1 to 6 of the key ones.
Is that when you say the chat on our
WhatsApp chat group? If you open that,
perfect. That's perfect. That really helps me a lot. Thanks, Joe. So the first question is a diploma or a master's better for pulmonology training? What would one go for? Master's or diploma? And I'm going to ask that to our pulmonologists. So if Sandra, what would you say to a aspirant candidate? Should I go for a master's or a diploma in pulmonology?
If they have time, they should go for the 2-year program. They should go for the MPhil and then the certificate in pediatric pulmonology, which is actually 2 years, if they have time. Yes.
How long is the diploma if they don't have time?
They do have a diploma. I know people haven't done that much, but I know there is a diploma which is a shorter duration. I think it's a year. But Norberta can tell us more about it.
Do you have any more information on that?
I think it's a year, but just to highlight that you can't do the diploma and then next time you add another year and make it a certificate, because I think under UCT it actually becomes a separate entity.
I can give you, if you don't mind, if I can just step in. So we created the diplomas for centres that wanted to have niche skills in specific areas, and sometimes they just needed a starting point to decide. But inevitably, as everybody's saying, when you come in and you realise what you need to learn, it gets bigger and bigger, and you often then decide that you want to, in fact, do the 2 years. So if you register for the diploma during the diploma time, you realise that actually you need the master's. If you flip to a master's before finishing the diploma, then you're okay. So for people that apply to us that are not sure, then we've allowed them to come in on the diploma. We actually prefer them doing the master's, and we increasingly encourage them, but we just wanted to give that flexibility, especially for people that couldn't be released for 2 years.
Thanks very much, Joe, for that. So the second question, and I don't know who it's come from, but thank you for these questions. Did any of you join from a private institution? It actually comes from, I suppose, I'm assuming it's come from Kenya. Did any of you join from a private institution? We have a few which are usually embedded with government centers, for example, Aga Khan or Gertrude's in Nairobi, Kenya. So I'm not aware that any of you were in a private institution, right? When you had come through, and maybe Joe, you might want to comment on that. If you
I don't think anybody was. So we started the program with a very socialist approach of saying absolutely only people from government and public centres, and certainly a lot of our partnerships and collaborations were like that. But the reality is that there's not always a neat fit. And actually, we're more interested in upskilling capacity within countries. And so I think Kenya is a fantastic example that, in fact, we've had really good relationships with Gertrude's and Aga Khan and the Kenyatta. And I don't think there's a single trainee who's gone back who has not, in fact, been symbiotic in helping all of the units wherever they are. So if there's a standalone, clearly siloed private institution where they're only benefiting a very small degree of the population and doing nothing else, and that's not really what we're about. But if it's a clear motivation where there's this kind of working relationship, then that's a different story. So we want to find ways to upskill access to knowledge in regions.
Okay, thank you. And then this question is directed specifically to Kunda. Kunda, somebody wants to know more about your training program, the neonatal training program. It sounds quite exciting.
Okay, thank you, Ashraf. So in Zambia, there was creation of the Zambia Medicine and Surgery, which was created, more like the PMSA. And this body is now in charge of recruiting people that work in various facilities to study where they are. And so using the ZACOMs, as we call it, we applied to, and through the Pediatric Association, the Zambia Pediatric Association, we applied to start this skill-based postgraduate diploma program, which is open, and the school fees are actually paid to ZACOMs. And so one comes to work in our unit for the 1 year, and then they get a diploma at the end. So currently we actually have a student from Uganda, we have a Kenyan, we have 2 from Congo DRC, and we also have some Zambians. So it's something that you can apply to and actually join.
Thank you very much, Kunda, for that. I'm looking at another question here. I think the question here is about what about the plan for rollout of more training centers? And I think that's, again, I think that's directed towards the APFP program. So what would be the plan for the rollout of more training centers? Again, Joe, do you want to comment on this? And I think you've sort of heard what people are doing locally.
I know.
But do you want to comment on that?
I mean, I think it's really evident that there's clearly a need and that we are now reaching the stage where we've got enough of a critical mass in many of the centres to do exactly that. So we've got the sub-Saharan training happening within South Africa, and Kenya is there to start setting up the East African and Ghana for the West African. But actually the reality is that you don't have to ring fence it, that you might find that in fact you can do a stepping stone of training, you can do modules in different places, and this is what makes us stronger and more collegial. The one thing I would say is I hope we've got over the detail and the attention that's needed. So it's not just a case of saying, I've got 2 people, I'm going to do it. It's a phenomenal amount of work, and that if you take it on, you need to take it on with that awareness. And I hope that we all can work together to do this and actually do it well. We learn so much from each other. We really, really do. But yes, the intention is there. Funding is probably one of the biggest limits, and time and capacity is the other one.
Thank you. Thank you for that. I see another question that hasn't come on the group, but it's about infectious diseases. How do I go about joining? And I think towards the last sort of 5 minutes of this, so we will come up, we'll be closing at the top of the hour. And I think we'll ask Joe to just say a word or two about specifically how to apply, and it will be directed to those subspecialties. So we won't go into so much of the processes of the application. Just going to look at any more questions.
Ashraf, if you don't mind,
Yeah.
I think Joe's tried to mention a few times that folks should recognize that if we have general PEDS training in our various countries, then it's not going to be duplicated under the APFP. The idea is that if it does not exist, though, then those individuals can certainly apply, and then they should also consider specialty training. I see a question from somebody in northeastern Nigeria who's talked about the APFP extending these privileges to people in this part of the disadvantaged society. And you know, the truth is that there's lots of good general pediatrics programs in Nigeria. And so perhaps what this individual is looking to have or have access to is a general pediatric program, first of all, and then determining which subspecialty will be most useful for them in that area based on what it is that they're missing out on. But I imagine, and I've worked in northeastern Nigeria a bit, I think there's certainly there's a need for general pediatrics. There's certainly a need for newborn care, and just at the very basic primary health care level. And there's a need to rebuild. So it's probably useful to get general pediatric training inside Nigeria. It's sort of cost effective, and then we'll support, you know, specialty training as is needed.
Sure. Those are the sort of questions that I've got already. I'm looking at to see if there's any other.
There's
Yes.
question 5, which is a great one that I'd love the group. And that was a question about how do you deal with the need for resources when you go back?
Okay, so anyone on the panel that would like to jump up and respond to that question, it's the need for resources to enable you to do what you'd like to do when you get back. How did you deal with that?
So Ashraf, maybe if I can jump in before others join. So I think the first thing is to lobby and negotiate why you need that kind of equipment and what kind of impact it's going to have. So if I can give you my example, when I came back, we had one EEG machine at our hospital, which was like maybe more than 30 years old. And there was a lot of issues with that equipment. And buying a new one would cost probably around $50,000 US. So the hospital could not really understand why they need to invest into that kind of money. So through collaborations and lobbying, we managed to get some colleagues who were able to donate one refurbished EEG machine. And once the hospital has seen what kind of impact that equipment has done, now the hospital is budgeting to buy that equipment.
Oh,
so I think it's important, number one, to be patient. Number two, to identify who are the key people in terms of key making decisions in terms of getting you the equipment that you want, and then selling your point to those people, particularly highlighting why you need that and what kind of impact that is going to have in terms of care to the people that you're serving. And if you do kind of that through other collaborations, then I've seen it has some little bit of effect.
So what I'd like to know is that when you go back home, and any one of you can respond, when you go back home and you've got a title, a certification that you are now a subspecialist, does it carry weight in terms of advocacy with your other hospital administrators or the Ministry of Health, where they say, they take it quite seriously rather than if you were just a general pediatrician? I'm just wondering.
Yes, Ashraf, I think people accept it, especially when you start small. So I'll still come back to my hospital and give the example of Professor Samson Entry and the first person who trained with the African Pediatric Fellowship Program somewhere in 2009. He's been phenomenal. And I remember doing his very first pediatric peritoneal dialysis with him. And it was more like not what would be standard in, for instance, the UK, where they have resources. But then it did save lives, and people began to realize that this is a potential area that we can invest in. I can also talk about our pediatric intensivist who, through advocacy, has been able to establish a pediatric intensive care unit, which is the first in West Africa. I mean, which we didn't have, but it's saving lives. So I would encourage people to start small and then continue being consistent. Don't give up. Yeah. Yes, anytime there's a need for something which resources do not have, put it down, write it down, and then talk about it to the people who make the decisions, the people who can make change in policy, and then continue doing the right thing. As Prof. Gray would say, change does really come. It may take time, but it does come. So, but if you give up, it will never come. If you don't start, it will never come. But if you are consistent, if people, you can show people that if I do ABC, it will change the situation. It can save lives. Then I believe that eventually people will buy into your idea. I mean, Prof. Entry is just about to set up his hemodialysis center, which is great. He has the equipment, he has everything. It's all through advocacy. It takes time. It's been almost 10 years, but it has happened. So I want to encourage people, don't give up. Start with the knowledge you have and become consistent. When you are called to see a patient, please go. Don't say, I don't have ABC, I can't do anything. Just your knowledge in making the right diagnosis is good enough. Sometimes you don't need all the extra equipment, you can save lives. I gave the story about the preterm baby who had the pneumothorax, 900 grams, that we managed to save by doing the simple Aprotec needle stick. I'm not saying we don't need advanced technology, but if you don't have it, you shouldn't also say you can't do anything. You should start something and you should continue to advocate. Any meeting that policymakers go, please attend. And whenever you go, try to, even if they don't give you a chance, try to ask one question that will help your voice to be heard. Do something, say something to people. And eventually, I mean, like now we have spirometers and we are doing spirometry because of one big research that we are involved in. We can do pheno, which I only saw in Red Cross. It is amazing, it is expensive, but it is in Ghana. So change would come, but you have to start. That is what I would say.
Oh, that's an absolutely inspirational and wonderful way that you've put it, Sandra. I can see how you are persistent and an excellent champion and an advocate. This is such a great discussion, and we could carry on and on, but I want to be respectful of all your time and all the audience's time. I think we've covered quite a lot of ground. I actually want just to end off with a couple of minutes, maybe Joe, just about the program again, and some of the practical aspects, and then to hand over to Orode to give the final concluding remarks.
Thank you, Ash, and thank you to everybody. I mean, I think it's been so interesting what everybody's been saying. So there are multiple questions that have come through on the question site and repeatedly, predictably, about wanting to apply. I would suggest look at the website, either through the slides or just Google African Pediatric Fellowship Program, and you'll find it'll come up, it'll take you through to the links. And several things: we will not duplicate training that's already existing in a country. There has to be very good motivation for that to happen. And the other point that Norbert has reminded me about is plan ahead. So if your institution supports you applying for a specialization, if it's within their strategic plan, then do it early. And because it takes us about a year for the registration process to go through, and it helps us to have up to 2 years to plan for the funding and to make sure that there are space allocations for the trainees, that if we can't accommodate them in your first choice, that we can then give you the option of one of your other choices, one of the other university settings. So to try and make sure that we accommodate as many people as possible. I think those were the key things. Ashraf, can you think of anything else, or guys?
No, I think you've covered it. I mean, I think the website will direct you as well to things that you need to know. Yeah, I think that's covered well. Orode, can we hand it over to you to make some final remarks? And I just want to say thank you very much to the audience for sticking with us. I think it's been an amazing journey of discovery of what our alumni have experienced.
So first of all, I want to say thank you to everyone who's been here and who stayed here for so long. Thank you very much, certainly, to all the panelists who made the time, made all the calls. It's been, you can imagine, with all of us being here, it's been a bit of planning. And I want to thank Joe, and especially Helen, whom we cannot see, but who has been the fastest fingers on the block for the past few weeks, just keeping us all organized. So thank you very much. So why are we training Africans on the African continent? Because it's relevant, because we can inspire one another to do better, to do greater, to just blow, things out of the water. I think it's really important, and I'm very thankful that we have the APFP, because not only are we modeling here the ability to train multidisciplinary teams, but also, as Bemi said, it's in ways that make people feel like they continue to be welcome. And we're actually starting to see the outcomes with research. We have 600 million children under the age of 18 on the African continent. We have no right not to be able to take care of our children, and we certainly must be able to train all of the specialists that we need to take care of our children: doctors, nurses, physical therapists, doctors, whether they be surgeons or medical specialists. So we need to build multidisciplinary teams. And collaboration is king, and that's why we're all here today as the APFP, working, being hosted by AFCHF. The idea is that we've got a long way to go, and every little step counts. I love Sandra's anecdotes. I love the way she sort of keeps it, just keep at it, keep at it. And Joyce shows us that you can do it. It's never too late. It's never too slow. You just keep chipping away at it. So I think we've come to the end of this afternoon, and I think to the end of this webinar, and I think we all can see that these are really important opportunities for us to collaborate, for us to strengthen the ability to train across the continent, and for us to really turn the spotlight on children and really begin to think about how are we going to ensure that our children are getting the kind of healthcare that they should have. I want to end just by saying a lot of African children are still in conditions of war or near war. And these children too, whether they be street children or children affected by Boko Haram or children affected in one or other of the many conflicts across the continent, children in conflict situations are also a very important type of child to consider. And we're going to have to start really focusing our attention on the mental health and the psychological makeup of our children. So this is another area where we really should be thinking, what are we doing with this? So I want to leave you all with this, just to say thank you very much again, Joe, Ashraf, and all the panelists, the APFP fellows and fellows. I think of myself as when I belong to a group like this, I'm a fellow forever. I'll always be known as a fellow. So thank you for your time. Thank you to our audience. Thank you for staying until the end. And please feel free to reach out to the emails on the last slide if you need any more information. And of course, you can get back to us and we will be happy to provide you with more information. Go to the website, it's available, and Joe and Helen will be happy to walk you through. Thank you. Bye-bye.
Thank you very much. Bye.
Bye, everybody.
Bye-bye.
Bye-bye. Bye-bye.